Today we have with us India's top vaccine scientist, Professor Gagandeep Kang. Thank you so much, ma'am, for being here with us.
Thanks for students.
So I'll start asking you a few questions now. My first question is, could you please tell us a bit about yourself and your journey?
So I did my training as a doctor at the Christian Medical College Fellow. So my MBBS was here. Then I went to AIIMS for a year to see if I wanted to be an ophthalmologist, but came back to CMC and trained in microbiology. When I finished, I decided I really wanted to do research rather than routinely running a hospital laboratory. So I joined the Division of Gastrointestinal Sciences and the Wellcome Trust Research Laboratory. That was in 1991. So I've spent 30 years doing almost always pure public health research.
That was wonderful to hear, ma'am. And my second question is, you're known as India's vaccine godmother. You were awarded the Infosys Prize, and you are the first Indian woman to be elected as a Fellow of the Royal Society for your contributions related to the rotavirus vaccine. Could you please tell us a bit about the rotavirus and how these vaccines were developed?
So one of the things that people do when they think about a career in research is think about what they want to study. And if you look at even medical students or biology students who are thinking about research, everybody's going to cure cancer. Everyone is going to solve major neurological problems or, be responsible for advances in cardiology. No one is interested in the more mundane aspects of life, like diarrhea. But if we think about it, in the world today, any given day, 200 million people have a diarrheal episode. And so the problem is huge, but because it is seen as something that is an inconvenience for adults, and we don't recognize how much of a problem it is in children, especially in rural areas, it's become one that we have ignored. So even now, today, if we look at causes of under 5 deaths, in low and middle income countries, about 9% of all deaths in children are because of diarrhea. That's a huge burden. We haven't shifted the needle on that really for the last almost 10 years. We've gone down from 11% to 9%. And to me, that's something that is under-recognized and unacceptable. So I've been focused pretty much on research on diarrhea. I'm just really lucky that I was able to be in a place that allowed me to study all aspects of diarrhea. So I have a lab. I run a clinic where we follow up a population of 150,000 people. So many of the children that are born in the area that we work in come into the many studies that we do. And we look at, we look at them when they are healthy, we look at them when they have diarrhea, when they have other infections, we look at nutritional status, we do a lot of observational studies, we do a lot of trials trying to see if we could figure out if we improve water and sanitation, for example, how much of a difference does that make to individual pathogens? Or if you look at zinc, which is an immune booster, can you make sure that children don't develop diarrhea? Or can you improve the performance of vaccines? So it was because we were studying diarrhea and specifically rotavirus, which is the agent that causes the maximum amount of dehydrating gastroenteritis, an acute watery diarrhea that kills children very, very quickly, that we got into vaccines. Now, with rotavirus, it affects rich children and poor children. Rich children have the advantage that if they get dehydrated, they can get to a hospital very quickly and doctors can start an IV drip on them. But if you're in a rural area and a child develops severe acute diarrhea, then there's nowhere for them to go. And unlike many other conditions where if a child is sick, you really know it and you react to it. In diarrhea, what happens is you become more lethargic, you become quieter. Essentially, a dehydrated baby just fades away. So it's not a problem that comes to people's attention. And rotavirus is the number one cause of that. So as soon as we knew that there was the possibility of a vaccine, we started to get into rotavirus vaccine research. So I've been working on rotavirus now for about 24 years, and for vaccine related research for rotaviruses for over 20 years. And the rotavirus vaccine, we were fortunate to be able to work with many people who were making rotavirus vaccines, many Indian vaccine companies. And we had a couple of failures, but we also had a couple of successes. And it's very exciting that in India, for all babies that are born in India from the end of 2019, every child in India is entitled to get a rotavirus vaccine that has been made in India. Two companies, Serum Institute, which is very familiar to everybody, and Bharat Biotech, also very familiar to everybody because these are the two SARS CoV-2 vaccines that we had first in India also. But we worked with them on rotavirus vaccines. We are working with them and other companies on other vaccine preventable diseases, as well as with the WHO and collaborators in India and outside.
That was really amazing to hear, especially since, like you said, people mostly try to go for tackle bigger diseases, bigger quote unquote problems like cancer, etc., etc. But they always, it seems that they always avoid the smaller yet bigger problems in a way. And it's honestly, being someone who wants to become a researcher in biology myself, it's really inspiring to hear that you can make such a big difference. My next question is, what is the deadliest virus that you've come across in your work over the years as a virologist?
I think you have to decide how you measure deadly. So if you want a virus that kills people and kills the bulk of people that it infects, you would think of a viral hemorrhagic fever. So something like Ebola or Marburg, these are viruses where you get an infection, your chances of mortality are pretty high, somewhere from 40% to 70%. In India, we have the Nipah virus. We had 18 cases of Nipah. Okay, I'm not sure that it was exactly 18, but I do know that from the 2018 outbreak, there are only 2 survivors of Nipah. Everybody else that got the infection died. So there are very, very deadly viruses, but the important thing to remember is that a virus that is that deadly is also one that we recognize quickly. And we know that if these viruses are spreading from person to person, then those viruses can be handled by containment, which is essentially really good quarantine and infection control practices. So with Nipah also, the medical staff that look after Nipah patients, as long as they follow infection control practices, full PPE, right? They can handle a virus that's as deadly as Nipah or as deadly as Ebola. You have to remember that deadly also means then small numbers. So instead, if we take a look at HIV. HIV has been with us for now almost 40 years that we've recognized it as a large public health problem. And for the first 10 years, it was a killer. You got HIV infection, you were going to fade away, get opportunistic infections, and die. And then we got antiretroviral drugs, and the first ones didn't work very well. And after that, we had ones that worked better. We have combination therapies. So we've essentially converted HIV into a chronic disease. You have to remember to take your medicines. But HIV isn't the killer that it was 30 years ago, right? You have something like SARS CoV-2, a virus that does not kill most people it infects. We know that. 80% of infections are mild or even asymptomatic. We know that even if you develop symptoms, your chances of getting really sick are relatively small. So if this is an infection that has actually a low case fatality rate, you would think this is not a deadly virus. And yet, in a year of being with us, 18 months of being with us, we've had hundreds of thousands of people die. And this is likely to continue to happen until we can get the entire world vaccinated. So defining deadly depends on what situation you're looking at. Is it an individual person's chance of dying if they get a virus, or how many people it kills in the world and when?
That's really interesting to hear, especially since nowadays, if you ask someone what the deadliest virus is, their answer would straight away be coronavirus. Coming to SARS CoV-2, could you tell us about the genome structure and how the mutations occur?
Sure. So SARS CoV-2 is a very, very large RNA virus. Usually, RNA viruses tend to be small, and they are small and have small genomes because RNA virus genomes mutate a lot, lots of changes. So every time the virus multiplies, you have a chance of a mutation occurring. SARS-CoV-2 is a large virus with a large genome, almost 30,000 base pairs. So what you would generally see is that this is a virus at the limit of the size that viruses can have. And it was able to grow to this size because, unlike most RNA viruses, this is a virus that mutates less. I know it sounds strange to hear that because everything that we are hearing today is about mutations in SARS-CoV-2 and the emergence of variants and how dangerous they're going to be. But actually, for an RNA virus, SARS-CoV-2 is quite a stable virus. Now, how do mutations occur and what are the drivers of mutations? A lot of this we learn in biology. Mutations occur because you can have insertions, you can have deletions, you can have inversions. Basically, the sequence of bits can be cut out, bits can be added, bits can be flipped. Now, there are drivers of mutations. For example, if you have physical exposures like ultraviolet light, that can result in mutations. You can have chemical mutagenesis that induces mutations. So there are lots of ways that mutations occur naturally, or mutations can be made to happen in the laboratory. We also now have ways of engineering mutations in the lab. For SARS-CoV-2, the reason that we are seeing so many variants and so many mutants is really because even though this is a very stable virus, there is a low level of mutations that happens. And because this virus is replicating so much, that low level of mutations, as a rate, it's small. But as an absolute number, it becomes very large because there are so many cycles of mutation. It's estimated that you're going to be producing 1 trillion particles. So you can imagine the number of trillions that have happened around the world so far. And that's why we are seeing so many mutations. Most mutations tend to be inconsequential. So they are just like spelling errors, American spelling and UK spelling, for example. So pediatrics with an A and pediatrics without an A for it. One way of thinking about it has no consequence. Everybody understands what pediatric means. Similarly for viruses. But sometimes you have mutations that have consequences. And those consequences can be good for the virus or bad for the virus. If they are bad for the virus, for example, they affect the virus's ability to replicate, then that particular mutation will die out because the virus can't replicate anymore. Then you'll have some mutations that are good for the virus. So mutations that make the virus more transmissible will be ones that will survive because they allow the virus to spread much better. And over time, that virus which is more transmissible will take over or dominate the population in which it is circulating. We've seen this now with the Alpha variant. We've seen this now with the Delta variant. There are also other mutations, like the mutations that help escape from immunity. So fortunately for us, among the combination of mutations that allow for a virus to escape immunity, the best example we've seen is with the Beta variant, which is the one that came from South Africa. Now, that variant, it's not like it escapes vaccines entirely. It escapes some vaccines, and it's still addressed by 2 doses of other vaccines. But fortunately for us, this is not a virus that spreads very well. So unlike the Alpha variant, which went all over the world, the Delta variant, which went very quickly all over the world, the Beta variant has entered into places but has not become dominant in many places.
I'm learning so many new things today, especially how mutations aren't always good for the virus. We were taught about these things in school, but I never applied it to the virus, to the coronavirus, especially. Um, Ma'am, there are so many COVID-19 vaccines that are now available. Could you please tell us a bit about the technology behind these vaccines and which vaccine, according to you, is the most pathbreaking, scientifically speaking?
So if we think about vaccines, we've had them with us since 1796. At least the principle of vaccination was established in 1796, and by 1800, we had started to make vaccines that were being distributed in many parts of the world. From those days of smallpox to 220 plus years later, we now have a plethora of technologies that we use to make vaccines. But essentially, there's 2 ways of thinking about vaccines. One is we make a vaccine where we give the whole of an organism that causes disease or a part of an organism that causes disease. Now, before we give it, we engineer it using a variety of approaches to make sure that it doesn't cause disease anymore, but it still induces the immune response. So there are many ways of doing that. But when we hear about inactivated vaccines, live attenuated vaccines, protein subunit vaccines, nanoparticle vaccines, etc., all of those vaccines are based on the principle that we are giving the whole of the infectious agent or a part of the infectious agent to people. Then the immune system recognizes that whatever these proteins, most vaccines are proteins, Some of them are sugars, polysaccharides, but those polysaccharides are usually conjugated also to a protein to make sure that the immune response is a robust and long-lasting one. So when you give this part of a virus or the whole virus or bacterium, very few vaccines are parasitic. When you give these to people, then the immune system recognizes that this is foreign. This does not belong here. We should kick this out. And in that process of kicking it out, we make an immune response. And we also store away the memory of what came around. So you have the immediate response, which shuts down whatever this foreign invader is. But also, we set up a mechanism where if it comes back again, we can recognize it and respond even faster. So, with protein vaccines, with inactivated, live attenuated other vaccines, it's always the response is to the virus or bacterium or a component of that. So that's one way of doing it. And that's the way we did it until 2018. Okay, all vaccines until 2018 were made that way. In 2018, we had the first Ebola vaccines licensed, which were vectored vaccines. Now, the new generation of vaccines is a vaccine where you don't give the whole infectious agent or part of the infectious agent. Instead, you very cleverly deliver to the human cell the message about how to make the protein. So you send in instructions. This is how you make the protein. The human cell receives those instructions. And just like it makes proteins for itself, for its own ability to function, it now starts to make proteins according to the instructions that it has received. And those proteins can be released from the cell or can be displayed on the surface of the cell. And the immune system then says, okay, here's something that's foreign, and reacts in exactly the same way that it reacts to the previous generation of vaccines that we had, where the protein was directly delivered. Here, you're not delivering the protein directly, you're delivering the message for how the protein should be made. So if we look at these new technologies, the vectored vaccines take a virus, adenovirus, vesicular stomatitis virus, measles virus, rabies virus, viruses that we know can get inside human cells, can replicate or be engineered to get inside but not replicate. And those are used like messengers. So it's like the envelope is a vector, and within that envelope is the instructions you have sent to the cell to say, this is how you make the protein we want you to make. So vectored vaccines, mRNA vaccines, DNA vaccines all work on the principle of delivering the message about how a protein is to be made.
Ma'am, my next question is, what helped us to develop vaccines so quickly for SARS CoV-2?
I think everybody is blown away by how quickly we made vaccines, especially when we first started out, because we were talking about the fact that the fastest vaccine that had ever been made before this was a vaccine that took 4 years, and those were the mumps vaccines in the late 1960s, early 70s. Ordinarily, it takes about 10 years to make a vaccine. So how come we made a vaccine in 10 months? We did it because we have new technologies. We did it because we've had 2 very dangerous coronavirus infections before this, SARS and the Middle Eastern Respiratory Syndrome coronavirus, which is still with us. And vaccines had started to be made for those coronaviruses. And because we understood so much about coronaviruses because of these bad experiences, we had learned that the spike protein of the coronavirus was the most important for inducing an immune response. A lot of work was already going on the different coronavirus vaccines. When SARS CoV-2 sequences became available, it was possible to build on everything that had been done before and very quickly switch all the other coronavirus vaccine programs to the new coronavirus. In fact, the Moderna vaccine famously was designed over the weekend, and it took 6 weeks to make enough of the vaccine to start clinical trials. The only reason that could be done was because the collaborations between scientists and companies that make vaccines were there, and the knowledge of coronaviruses was already there. Of course, that was necessary, but it wasn't sufficient. And what gave it that sufficiency was that academia, government, industry worked together with regulators to make sure that we could test these vaccines in people as quickly as possible. So one of the things that we did also was throw more money at the development of coronavirus vaccines than has ever been invested in a vaccine program anywhere for any disease. The US alone spent $18 billion to develop coronavirus vaccines. The US currently has 4 vaccines, 4 coronavirus vaccines. It's really using mostly the mRNA vaccines. Now, usually it costs about $500 million to make one vaccine. And that 18 billion just shows us, out of which about 12 billion was directly investment in vaccine development, manufacturing development, is we overspent. And we overspent so that we could do lots of things at the same time, instead of the usual process of vaccine development where money is always a constraint and you go step by step. Here, instead of doing one step, seeing whether it worked, then going to the second step, seeing whether it works, then going to the third step, seeing whether it works, here you had lots of step 1s, lots of step 2s, some step 3s, and finally products. So that funneling effect, which was enabled by investment, was also a key part of us being able to get vaccines really quickly.
Ma'am, I feel like the really thin silver lining to this whole pandemic is how it's acted as some sort of unifying force. Of course, it's unfortunate how this force came about through a pandemic, but the fact that there were so many investments really does show that we can all really work together and create something in a short period of time, but something that's going to end up helping a lot of people and is helping a lot of people.
Well, just think about it this way. We call this biodefense, right? But compare the amount of funding that is spent on biodefense versus defense, right? Countries the world over invest in their armies, navies, air forces. And how many deaths do you have in war every year? You make the argument that we have armies, navies, and air forces so that we don't have deaths in war, right? Do we invest that much in biodefense? We know the viruses are coming as a predictable threat. How many outbreaks have we had in the last 20 years that have crossed continental borders? You've had SARS, you've had H1N1, you've had MERS, you've had Zika, you've had SARS CoV-2. These are just the ones that we know about. I'm sure there are many more localized outbreaks that occur in many places. If we took even a fraction of the money that is spent on armies, navies, and air forces and put that into biology and ecology, I think we'd be better off.
Biodefense acts as a way to unify people, whereas defense in a way separates people even more. Now my next question is, could you please tell us a bit about mRNA technology that enabled the mRNA vaccines development for SARS CoV-2?
Okay, so in mRNA, the reason that we actually have mRNA vaccines is because of experiments that were published in the early 2000s. And these were from Caitlin Carrico and Drew Weissman at the University of Pennsylvania. Before this, people hadn't been able to use messenger RNA as a way to deliver messages into cells, because RNA itself is a very inflammatory molecule and you can't get too much of it into a cell. It breaks down very, very quickly. So what they did was to show that you could engineer an mRNA vaccine, an mRNA molecule, to be able to reduce how inflammatory it was and also to make it more stable so that more of it could get inside cells. So those key experiments in 2006 were the beginning of mRNA technology. And initially, mRNA has been applied way more for cancer than it has for infectious diseases. So the idea there was, could you get mRNA into cells so that you could send out, you could make proteins within the cell that would counter the ability of the cell to be malignant. Now, in the case of mRNA vaccines, what you're doing is way simpler than that, which is just delivering the message about how to make a protein. This mRNA molecule, even though it has been engineered to be less inflammatory and more stable, has higher yields, still has a problem that it breaks down very, very quickly in the body. So in addition to all the efforts about engineering the molecule itself, there had to be efforts to see how this molecule could be packaged so that it could be safely delivered into a cell. And that's where formulation comes in. And mostly what companies have done is figured out a way of making a soapy layer of nanoparticles that surround the mRNA, and then it's protected while it gets inside cells. The soapiness or the lipid layer that it has also allows it to integrate very well with the cell membrane of the host cell and deliver the mRNA into the cell. Once the mRNA gets into the cell, it goes to the protein producing factories of the cell, the ribosome. It delivers its message there. That message is read and translated, and amino acids, according to the sequence of the mRNA, are brought to the ribosome, linked up together to make protein.
Exciting to hear the topics that we do in school being applied in real life. According to you, which vaccine will be better efficacy on COVID-19 variants of concern?
Right now, it's looking like the mRNA vaccines are working slightly better than some of the other vaccines. What does seem to be clear is that there is protection from vaccines against variants. It's less good for some vaccines versus others. But in terms of real world evidence, we have a lot of evidence against multiple variants right now, only for the mRNA vaccines and for the AstraZeneca vaccine. We have bits of evidence for the inactivated vaccine coming from different parts of the world showing that maybe they are not working as well. We have evidence from clinical trials for the protein vaccines like Novavax, saying that they work a little less well against the beta variant than against the alpha variant. We don't know their effect against the delta variant. These will emerge once we start to use vaccines much more. But right now, it looks like for the beta variant, 2 doses of the Pfizer vaccine works really well. For the alpha variant, all the vaccines seem to be working reasonably. There's a reduction, but a small reduction. For P1, which the Brazilian variant or Gamma variant, we know less about that. We do know that the inactivated vaccines are working to some extent against that because it is the dominant variant in South America, or at least in Brazil at the moment. For the Delta variant, we have data from the UK showing that both the AstraZeneca and the mRNA Pfizer vaccine work, but the Pfizer vaccine works a little better than the AstraZeneca vaccine.
Thank you so much for that clarification, ma'am. And my next question is, in a recent development, FDA has denied the approval for covaxin under emergency use authorization, which has raised some concern. Should we be worried despite the fact that it is based on conventional technology?
I think we need to understand that the FDA is a regulator for the US. So their responsibility is to see where is emergency use authorization appropriate for a new technology wanting to enter the US. They gave emergency use authorization to the 2 mRNA vaccines and to the Johnson & Johnson vaccine, right? Now, the Johnson & Johnson vaccine is not being used very much in the US at the moment, even though it is a single dose vaccine. When you have enough supply already and you have a vaccine available with you that's not being used very much, why would you want to give emergency use authorization to yet another new technology? AstraZeneca and Novavax have already conducted large-scale clinical trials in the US. 30,000, 40,000 people taking all the participants in the trial, including tens of thousands in the US. Now, those 2 vaccines haven't yet, Novavax is not even going to apply until September, and they have all of their clinical trial data. They are most likely going to be asked to apply for a full licensure because that's the next step after EU. So I don't think we should view covaxin's rejection for an EUA as something that means that there is something wrong with the vaccine. We have to look at it from the US point of view of, is this right for them at this time? And it's clearly not.
Thank you so much for the answer, ma'am. This is a question from one of my viewers. Is it advisable to take the antibody test before taking the second dose of COVID vaccine? And is there an optimum antibody range?
So we don't have an antibody test that we can do today that guarantees that if you have this antibody at this level, you are protected from infection. So that is called a correlate of protection, a test that can tell you that you are protected. There is no such test available at this time. For other vaccines, do we do antibody tests before or after we take a vaccine? We don't. Why are we exceptionalizing this virus? We're doing it, I think, because, well, we have very little else to do, since many other activities that we have in normal life are not happening. And there is a lot of focus on this virus and understanding your individual response to the virus and what it's safe for adults to do or not do, we will ultimately wind up getting either a correlate of protection, or we will get something that we can call a surrogate correlate of protection, a measure that tells us with some degree of confidence that if you have this much, then you're protected of this, this much of this antibody you're protected. It's likely that the functional correlate, the one that actually gives us protection, to some extent will be neutralizing antibodies. None of the commercially available tests actually are measuring neutralizing antibody tests. There is one made by a company called GenScript. It's not that widely available, and even that, we don't know what level of neutralizing antibodies you need to have. Most of the commercially available assays are just measuring antibodies, either total or IgG, to the spike protein or to the nucleocapsid protein, or combinations of spike, nucleocapsid, and membrane. Now, measuring those antibodies tells you that you have had exposure or you have been vaccinated if you have the antibodies. Not having the antibodies does not mean that you were not vaccinated or not infected before, because antibodies rise and then they come down after a while. And if you had a low level of antibodies, they may have disappeared by the time you took the test. It does not mean that you have no protection. So my advice, don't bother. The only situation where I currently know that that getting an antibody test makes a difference to the person who is getting the test is with the new data that has come out for the use of monoclonal antibodies made by Regeneron, where if you are previously uninfected, seronegative, then the Regeneron antibodies work well in people who have severe disease. If you are seropositive, the Regeneron antibodies, which are very expensive, don't work. So therefore, to make a decision about whether you need those antibodies or not, if you're really sick, you need to have an antibody test. That is the only individual level application that I know for the test at this time. Otherwise, for public health use, it makes sense because you want to try and figure out how much of the population has been infected. So those are the sero surveys that we do. They're a very useful public health tool, but you don't use that at an individual level.
Thank you for that clarification. I think that cleared all doubt in my mind as well as my viewers' mind. The Pfizer vaccine has been recently approved by the FDA for children over 12 years of age, and that's a very positive step towards normalcy. Since Pfizer vaccine is not available in India, do you think any other vaccines that are available in India are safe for children?
I think ultimately we'll find that all vaccines are going to be safe for children at the same way that they are safe for adults. The question really of a benefit risk assessment is how much does it benefit children to have the vaccine? And the thinking is that actually at the individual level for a child, there's very little benefit in receiving the vaccine, because most children who are infected are asymptomatically infected. The proportion that develop severe disease is a small proportion. Now, this is thinking from a public health point of view, thinking that, most of the doses of vaccine that you're going to use in children are not going to save lives. Because if you use those same doses in a population of people over 60 years of age, the number of lives that you would be able to save would be in the order of hundreds of times greater. Okay, so from a public health point of view, vaccinating children for individual protection of children from severe disease or death is very small. However, you bring transmission into the mix. The fact that uninfected or unvaccinated children can circulate the virus, can spread disease to their peers and at home. And the fact that this is an infectious virus, so if children are not protected from this virus, then spread will continue to happen. Now you need to bring this into the mix as well. And here, if you have a high level of circulation of the virus in the community, it makes sense to vaccinate children. Now, it's not like no children ever develop severe disease or, children die. It's a small component, but it happens. So at the individual level, it then becomes a choice that you need to make. Do I want to be sure that I'm protected from infection and severe disease? That's only going to happen with 2 doses of vaccine. However, with every vaccine, there is a risk. So mRNA vaccines, for example, cause a myocarditis, an inflammation of the heart muscle. It's a low-level risk, but with millions of doses of vaccine, it happens. And there's a chance that you could die because of the viral myocarditis. With the AstraZeneca vaccine, we know about thrombosis with thrombocytopenia. Both of these conditions are completely unpredictable. They are very rare probability events, but they are a risk. So there is a risk to taking vaccines, and there is a risk to not taking vaccines, and therefore having the small chance that if you get infected, you might get severe disease. Not an easy choice to make.
Definitely, ma'am. Could you please tell us a bit about CEPI and Disease X?
So the Coalition for Epidemic Preparedness Innovations, or CEPI, was thought about after Ebola. Basically, in Ebola, there was a vaccine that was sitting in a freezer and had been sitting there for 10 years. In 2014, when Ebola struck West Africa really badly. And it took almost 10 months for the world to get its act together and get into position to do clinical trials with the Ebola vaccine in West Africa. By the time they got around to doing the trial, the number of cases had declined because good infection control practices, good treatment practices had been put in place. Once the vaccine was used, it was very clear that it was an excellent vaccine. And people thought this is crazy. The fact that we had an effective vaccine and we weren't able to use it because we weren't ready. So the thinking around CEPI was, what is it that we can do? Can we have a global organization that thinks about outbreaks, that develops vaccines with partners for outbreaks, so that when outbreaks happen, then CEPI can step in, make sure that vaccine manufacturers are funded, that governments know what to do, and we all work together to use vaccines effectively. So CEPI was established as with 5 founding partners. India's Department of Biotechnology is one of the 5 founding partners. It was also the World Economic Forum, the government of Norway, the Wellcome Trust, and the Bill and Melinda Gates Foundation. Subsequently, very quickly, the governments of Japan, of Germany came on board. And since SARS CoV-2, we've had many other governments from Ethiopia to Mexico joining and supporting the mission of CEPI, which is essentially to get vaccines developed fast and used fast. So CEPI was able, because it was already working on MERS, CEPI was able to transition the Disease X program and the MERS programs to making vaccines for SARS-CoV-2. The idea of Disease X is, can we have platform technologies like mRNA or like vectored vaccines, where you can very quickly once you know the sequence, you very quickly switch out the message to the new pathogen that you're trying to deal with. So as soon as disease X appears, get it sequenced and be able to make a vaccine quickly. So with Moderna, with Oxford, that's exactly what happened, that the programs that already existed for disease X and for MERS were switched to making vaccines for SARS CoV-2. So CEPI also is part of the COVAX facility, where equitable access and making sure that people have access to vaccines is something that is followed up on with a lot of different players, WHO, Gavi Alliance, all working together with industry to make sure that vaccines reach people as quickly as possible. It's been challenging. Supply has been so limiting that many of the idealistic assumptions of CEPI weren't quite met. I guess the scale and the rise of vaccine nationalism, although they were anticipated, their impact was not quantified quite as well.
It's quite reassuring to hear that there's this whole organization dedicated towards outbreaks and stopping outbreaks worldwide. My next question is actually about you, ma'am. It's what has been the most defining moment in your professional life?
The good ones or the bad ones?
Any is good.
So there are always lots of highs and lots of lows, but if I was to pick one, I guess it was the time when we had the DSMB, which is the Data Safety Monitoring Board. So when you do a vaccine trial, you don't know who's gotten as an investigator, as a researcher, you give what you think is the vaccine to everybody, but actually only half of them or 2/3 of them get the vaccine, and half or 1/3 will get a placebo, something that looks identical to the vaccine but isn't. And then the data are analyzed by an independent group, and there is a data safety and monitoring board that looks after both the data and the welfare of participants in the study. Because, for example, if something is going wrong, as happened in our study, we had children that developed seizures and we didn't know what was happening. So the DSMB put a hold on the study, analyzed the data, came back and said, actually, the cases are distributed across the vaccinated and unvaccinated children. We need to look for another cause. And we finally figured out that this was the height of summer and these children were dehydrated. So then, hydration became something we attended to. So the Data Safety Monitoring Board looks after safety, but it also does data monitoring, which is independent evaluation of the data. So when you do a vaccine trial, you have to you use an approach which is called case counting. And you say, okay, if I get 150 cases, then that's the point at which I will stop, take a look at the data, figure out if the vaccine is working or not working. And for us in the rotavirus vaccine trial, it was the first time there was a phase 3 study for a newly developed vaccine being done in India. We knew that the rotavirus vaccine was not going to work as well as it had worked in the US. The question was, this is a completely new product. Is it going to work at all? And the DSMB members came out and announced, after too much talking, in my opinion, that the vaccine actually had 55% efficacy. And that was phenomenal because, we thought, we'll be okay if it's 40%. Our most ambitious projection was about 60%. And it was working, and it was near the top end of the estimate that we had. So that was phenomenal to know that we had an Indian vaccine that was going to work, and the potential that it had to affect not only deaths but also hospitalizations in the country. So, yeah, pretty spectacular. We did break out a bottle of champagne.
I think it was well deserved as well. Now my next question is, why do we see fewer women in positions of prominence in STEM?
I think that's really society. The fact that in India, less than a quarter of all women work. And it seems crazy that even if we look at the middle class and the upper middle class, many women drop out of, may get a great education, may get a professional education, be lined up to work, start working, and then drop out because they have to look after families, they have to, not just children, but families as a whole. Or they have to figure out whether their husband's career matters more than their own. And the structure is such that women staying home is perfectly acceptable. Men staying home with their children is such a rarity that we hear about, I think, almost every individual example where that happens. So I think it really is about society. It's also about the fact that we don't have organizations that allow for women to be flexible in their working. I personally find that, women work as hard or harder than men. All you need to do is provide them with support to be off when they need to be off and flexibility in how they do their work. And if you do that, they will be equally, if not actually more productive than the men who work in my team. And certainly when it comes to teams, women do really well because they are collaborative, supportive in many ways that takes a lot more effort to build up on a male dominated team. I prefer a mix. So with my field staff, when I first started out, I was told to hire male field workers because we were going to give them mopeds to go into these gullies where in a slum population, the roads are narrow, traffic is heavy. So we said, okay, because they need to travel several kilometers, it just is harder to arrange, cycles are not good enough and we can't have a central transport mechanism that gets into narrow streets. So they have to learn to ride mopeds or have mopeds. And everybody said that, the women won't do it. I said, we'll hire the women and we'll teach them. And then the whole team goes out together. So this was more than 20 years ago. So now it's an accepted fact that we have as many women as we do men. We use men for many of the programs. We work with women and children. So women work very differently with families and communities than men do. But I think they've all learned from each other. So my field teams are phenomenal. They're just so experienced. They tell you that they fight with me all the time about the families that need support and how they need support and why am I not doing this for them. So I think that's a great way to function.
It's really wonderful to hear the sort of collaboration that goes on, especially in your workplace. And I completely agree with you because I think it is, and I've said this before, that it's so damaging society's expectations of women to take care of the home and hearth, whereas men, I feel like, if taught, or not only taught, are equally as capable as women. just as how women are equally as capable, or if not more capable, in the workplace.
Yeah. No, my kids were taught to, well, one of my sons does a lot of cooking, the other one cooks with reluctance. But I think what came home to me also was a time when my son was maybe 4 or 5 years old, and I was washing dishes, and something he said made it sound like this was a gender specific role. So I got him a stool and he washed the rest of the dishes.
It's really nice to hear because we're all growing up. I'm growing up in a male dominant society where men are seen as superior. And I think just taking away from that and just tearing that apart, that whole idea apart at the base level, is the best way to approach it. And my next question is, and we're slowly nearing the end. Um, did you personally ever face gender bias in your journey to the top? And what would your advice be to women in STEM?
Who hasn't really? So I'm at a stage where once I was able to attract independent funding, lead my group, I had a lot of independence within the group to do what the way I wanted to do things. But in dealing with the environment, even at my institution, which was established 120 years ago to teach women, Indian women, medicine, right? So since 1918, this has been a school or a college where the focus has been on educating women to play roles in medicine. Even in my institution, when I actually did an analysis about 15 years ago, I found that while among students we are equal, among incoming assistant professors, we are equal, but the higher you go, the fewer women that you find. And when you get to leadership positions, even though this was a women-led institution for the first 60 years at least of its existence, over time what has happened is that the senior positions are about 2/3, 1/3. That's still better than most other institutions in the country, but I don't think it's good enough for us. And part of the reason, I think, is our own conditioning as women, that we are taught not to put ourselves forward. The idea that a woman who presents herself, who speaks up in a group, is somehow difficult, right? And we need to learn that we have to be different, because we have every right to be at that table, to be in that space, and we bring to it something that adds value.
Yes, ma'am, I completely agree. And that was really awe-inspiring to hear because I completely agree with that. Um, Women are underrepresented in STEM fields, but have made significant contributions and played leading roles in scientific research and development of COVID vaccines. Could you please shed some light on this?
I think you've said it all, that wherever women have been given the opportunity or made the opportunity for themselves, they have contributed in ways that are not measured sufficiently. But wherever you do a deeper dive, you will find the many ways that women have contributed that are not recognized. So I think what we need to think about is a future that gives people the opportunity to contribute as they wish, and a society that creates those opportunities for them. You may choose to make choices. You may choose, this is the year I want to travel the world. This is the year I want to take off and spend with my family. But those are choices that you should have the opportunity to make. Those are not a decision that needs to be thrust on you. And that's true for, I don't think there's anything special about STEM. I think this is represented as a women in STEM or women in STEAM problem. But I think this is a women in society problem. It applies across the board in every occupation, in every profession. The only place where you see more women than men, and even that is changing, is maybe in frontline health workers and in the nursing profession. So here also we have the greater entry of men. And what I see is when you have a women-dominated profession, teaching, or some kinds of teaching, nursing, this frontline health workers, the value of that profession goes down. And when you have more men in a profession, the value of that profession in society goes up. And that seems nuts to me, because the professions that we are talking about are actually the ones that build tomorrow's society. Teaching and healthcare and frontline healthcare. There is no society that is successful without education and without health. So this is a systemic problem, it's a societal problem, and we have to continue to shine a light on it so that it's recognized, because if we don't recognize it, we won't try to fix it.
Yes, definitely. Thank you for your answer, because I, being someone who feels very strongly about women's rights as well as several other issues like this, I never really thought about it from that aspect, about how the value in professions goes down. So that's really interesting to hear, but also not shocking at the same time. My next question is, were you interested in science since childhood, and what was your inspiration?
I was interested in everything as a child. So I guess I was reasonably introverted, and because we moved around a lot when I was a kid, we spent a lot of time reading, and reading opens up your imagination. Reading gives you information. So I used to think about all kinds of things, but I loved history, I loved geography, I loved all of the sciences. And a lot of how much you like a subject depends on who's teaching it to you and how exciting they make it. So maybe in some ways, in some fields, I compensated for bad teachers by reading. So for example, for physics, if you read Richard Feynman, he kind of opens up physics for you in a way that even the best physics teachers we have don't. So I also had the advantage of having a father who was an engineer, who was willing to spend lots of time with his children. So my sister and I had the opportunity to do a lot of things with him. So whether that was, we lived in small towns where it was very challenging to have lots of exposures. But whenever we went to cities, we went to museums, all kinds of exhibitions, and we frequently brought things back that allowed us to continue to learn at home. So very much learning by doing. So we established physics labs at home. We did chemistry at home. We did, well, my father was an engineer. He didn't enjoy the biology, but I had an uncle who was a doctor who did. So learned a lot from him, including, I remember, why using a towel to dry your back requires a level of coordination that is not feasible for many other species.
That's quite fascinating to hear, actually, how you were able to compensate for living in a smaller town with these wonderful experiences with which I almost wish I had growing up and now as well. Um, my next question, and my second last question actually, is what would be your advice to anyone, especially girls, who want to pursue a career in microbiology and virology?
I think I have the same advice for everybody. The first one is you have to believe in yourself. What we do as a society, particularly in India, is that we are very frequently very good at pointing out problems. Problems with behavior, problems with your ability to perform in school, on a sports field. It's more like we think that pointing out flaws is going to help people. It doesn't. It needs to be the other end of the spectrum, which is, you're fantastic, everything that you do is fantastic, works at home, but doesn't work in the external environment. So we need a balance of both of those, and you can only have a balance when you actually have a clearer view of your capabilities and recognize the positives as well as the negatives. And you have to work to accentuate the positive. What is it that you can do, that you are good at, that is a good contribution to the field? Some people are very individualistic, don't work well with others. Others perform beautifully as teams. Many people are good coaches. So recognizing what you have and what you are bringing to the table is very important in every profession. If we think about microbiology and virology, I think I have a passion for this because these are invisible bugs and every story is a detective story. So you're constantly trying to figure things out. Why does this happen? Where does it happen? What does it mean? So a lot of fields in medicine are like that. So if you enjoy finding things out, then these might be fields that you'd be interested in.
Thank you, ma'am. That was, being someone who's actually considering microbiology, I think that really helped clear my perspective a bit. My last question is actually a special request from my viewers. Will we ever be able to go back to school?
Of course, you'll be able to go back to school, just that schools may not look like what you had before. So the biggest thing to recognize is that we are at the early stage of this pandemic. This is a virus that has established itself in the Indian population, in the global population, and we are learning many things about the virus and what interventions work for us. Some things we know already, which are very powerful pieces of knowledge. One is that it is a very transmissible virus, and it has the ability to increase its transmissibility, right? With the variants that we have seen, they've become more transmissible because most likely you probably need a fewer number of viral particles to get infected. So for example, maybe with the ancestral version of the virus, you needed to breathe in 1,000 viral particles to get infected. Now we may get infected with 300. So if that is the case, then the kinds of interventions that we need are very different. The distance may need to be further away. The amount of ventilation that is in a room may need to increase. The quality of the mask that we need to wear might need to change. So we are learning as the virus evolves, but we are learning very quickly. We've managed with incredible effort to make vaccines that are working more brilliantly than we ever imagined. If you had told me this time last year that we were going to have a vaccine that had 90% efficacy against a respiratory virus, I would have said in your dreams. Okay? But those dreams actually came true. I was expecting a really good vaccine to play out at 75%. And we are now talking about more than 90% individual protection against severe disease and a decrease in transmission, because there is protection from not just disease but from infection as well. So that gives me hope that once we get the rest of the world well vaccinated, once vaccination starts to come down into children, we will suppress virus replication. We won't very quickly be at a point where we could completely get rid of the virus. We will be able to control it very well. We will have advances in testing technologies. Can you spit into a tube and see who's infected or not before you come into school? This is already happening with nasal swabs in many schools, with children who are attending in-person school being sampled twice a week. It can happen. And when it does happen, when the combination of all these things for all of society as well as for children happens, we will be back in school. The distances may be a little further apart. The ventilation may need to be a little better than we have it today. There may need to be more screening processes in place, but there will be school. The one good thing I will say is that the next time you say you're not feeling well, you've got a cold and you've got a fever, the school and your parents will tell you to stay home instead of sending you off.
That was definitely relieving to hear, because I really miss school so much, and I know a lot of people do, and we're just all waiting to get back. Ma'am, I am sure you've heard this many times before, but you're truly an inspiration for all of us. And thank you so much for taking out the time to talk to us.
Happy to do that, Ehsaas, and all the best with the Loony Scientist.
Thank you so much, ma'am. I really, truly appreciate it, especially coming from you.